working. We have Citrix working with us, and I'm going to turn the show over to you. Thanks for being here.
Welcome to GoToWebinar. Web events made easy. Please enter your
So can you see my screen at this point?
No, Richard, we need to get his...
Okay, I'm going to show my screen. Okay,
there you go.
Joining
When we see it, I'll let you know.
Please enter
There
your
we go.
audio PIN
We're seeing you
followed
now.
by the pound or
Perfect.
hash
Okay.
sign. If you do not have a PIN, just press
All right,
pound
here we
or
go.
hash.
And
So
whoever
everybody
is not muting, mute yourself, please.
An attendee in listen-only mode.
asking therapists to mute themselves.
I know.
Well, that's a trick.
Yeah,
Okay, so
I know
you can.
this technology, and I know you know the headaches with it.
Absolutely. So you can see my screen now.
Yes, your screen's perfect. Thanks.
Okay. Well, thank you. I really appreciate being invited to give a talk today. It is my honor. So without further ado, I'll just jump into it. My name is Nicholas Dogris, and I am the developer and owner of Neurofield, which is a form of low-intensity electromagnetic therapy. So let me jump into this here, get my screen to change. If I can get it to change here. Okay, there we go. I'm a health psychologist. I've been in the field now for, well, I like to say over 20 years. I've had a lot of experience in working in the neurofeedback field, and I started in the late 1980s, and initially did work with Dr. John Morgan at Humboldt State University, and then moved to Los Angeles and met Dr. Dan Staso and did some work with him, and worked in an inpatient psychiatric facility for 7 years, a number of county mental health facilities. So it's been a very interesting road. In the late 1990s, I met Margaret Ayers, who was my, I'd say she was my real introduction to the notion of neurofeedback being a treatment modality. Margaret had a huge impact on me because trained as a health psychologist, I was prepared to move to New Mexico with my wife and be a prescribing psychologist. And after meeting Margaret and watching her take people out of coma, that pretty much changed my perspective as to what was possible, and diverted my path, my career path. Everybody has a reason for doing what they do. Here's mine. AJ, my son, was born hypoxic. He had suffered from magnesium toxicity. Basically, my wife went into labor 2 months early, and in an attempt to stop the delivery, the doctors gave her high doses of magnesium, which suppressed his nervous system, and he was born blue. And this is my first view of him, meeting him 3 hours after his birth. It was roughly about 2, 3 o'clock in the morning when I met him. I distinctly remember standing there thinking he had suffered from hypoxia. And with all the experience I had working with Margaret up to that point in time, I knew that I would have to treat him. But I also knew that with my current skill set, I would have to learn some other ways of being able to help him. This is us now. Fortunately, he's responded well to the things I've done with him, and he is mainstreamed and doing great. This is a child that had virtually no speech at 18 months and was not ambulatory. But now he's a fully functional mainstream kid, actually challenging me quite a bit. So I initially treated him starting with the lens system. I was very interested in using that because I had an understanding that it would be easy to use that system with infants. But the lens plateaued eventually, and I knew that I had to find another way to help him. So in my search, I came across transcranial magnetic stimulation, which was originally developed by Alan Barker in 1985 in the UK. Dr. Barker wanted to find a way to pretty much substitute the use of electroconvulsive therapy, which psychiatry was getting a lot of, they were getting a lot of grief for such an aggressive therapy. I found TMS to be very, very interesting simply because it seemed like it would be a way to reset the nervous system and get it to reorganize itself. But when I started looking at it, I realized that medicine had created a way of working on the brain that was really aggressive. And it was 1 to 3 Tesla of stimulation that was being given initially with RTMS. And in looking at it, a huge coil would be placed on the left side of your head, and this coil essentially would be turned up to such a degree that it would force a depolarization of the neuron so that your right hand would basically twitch, which was called a motor response. And in TMS literature, we would try to find motor responses to prove that there was some kind of stimulation. One moment, please. Sorry, there's some background noise here. Okay. And so when I started to look at EMF versus other kinds of therapies, another therapy was obviously direct current, which is tDCS. The original kind of direct current obviously was electroconvulsive therapy, where enormous amounts of current was applied directly to the skull in order to influence the brain. Both therapies, in my opinion, are very aggressive. However, TMS has been evaluated for 2 decades now, and there's an enormous amount of research showing the effectiveness of the actual therapy. The FDA has approved TMS for the treatment of depression, and in 2008 it was deemed safe by the FDA to apply this 1 to 3 Tesla stimulation to the brain. So in looking at TMS versus what Neurofield does, I was very satisfied that Neurofield, I was very convinced that Neurofield would be a safe modality to experiment with. So let's talk about what Neurofield actually is. Initially, when I developed the device in 2007, I did not have the intention of releasing it to the public. This was a device that was specifically designed for my son, and the engineer that was working with me had every interest in helping me, and we were talking about different ways of just simply creating this technology and not releasing it to anybody. But then once clinicians started to see it, some of my close friends, they really encouraged me and almost demanded that I release it. So Neurofield itself is a 4-channel frequency generator. It has a frequency range that runs from 0.31 to 300,000 hertz. The electromagnetic field that's generated from the device runs from 1 to 500 milligauss, or 1 to 50 microtesla. And to put this in perspective, like my little PowerPoint suggests here, the intensity difference between RTMS and Neurofield is 10 million times weaker than actual RTMS. So when you actually look at how intense Neurofield is, it is a very, very weak pulse. As a matter of fact, as we're going through our FDA approval right now, the FDA has already defined what RTMS is, and when they look at Neurofield, technically we don't exist. The weakness of the Neurofield pulse is something that the FDA doesn't even know how to deal with now, because nobody has ever done something so weak, which is pretty interesting. So we decided to release this to the public, and we started to develop different procedures over a period of 5 years. There was a lot of hit and miss with Neurofield. Some of the stuff that we did really worked well, and then some of the stuff we did absolutely had zero effect. And the great thing about it was we had 10 licensed clinicians across the country that were conducting a field test, and we all would compare notes on this Yahoo group. And when we started to see what was possible, it became very, very exciting. So we continued to experiment with the technology. We added EEG and HRV into the system, and then we added the NeuroGuide real-time Z-score to the system as well. Now, some of the things about Neurofield that it's important for people to understand, I always get this question, how does it work? Why does this really weak electromagnetic field have an impact on the brain? After all, RTMS causes a depolarization of the neuron. How is it that Neurofield could even do something if it doesn't force the brain to fire? One of the first things that we discovered was that the brain will copy any EMF that you feed into it. So if I give the brain a 10 hertz pulse, the brain will start running at 10 cycles per second. If I give the brain a 5 hertz pulse, it'll start running at 5 cycles per second. We know through repeated experiments and experience that the brain will mimic whatever we give it. So once we figured that out, we knew that we could exercise the brain, essentially, very much like one would when going to physical therapy. So I bought a FLIR camera and started taking picture of the frontal lobe of people prior to a session and right afterwards. What we noticed was a significant increase in capillary blood flow. Then what we started to also see that inflammation would reduce in many of our patients. Some of the Neurofield practitioners are acupuncturists that feel very comfortable administering the EMF not to the brain but to different parts of the body. And they began reporting that inflammation would reduce significantly within a 24-hour period of time. The literature also supports this, and we found that EMF therapy not only would reduce inflammation, but has the ability to be able to facilitate healing, and specifically in bones. You can actually see there's devices that are sold by companies now that facilitate bone mending, essentially. Now, one of the great things about Neurofield is, since it's a very low intensity EMF device, we can deliver frequencies at very fast speeds that typically cannot be given by RTMS devices. So Neurofield is able to give a 10,000 hertz pulse, for instance, and not cause any damage to tissue because it does not generate a great deal of heat. At 1 to 3 Tesla of EMF, what we typically see is very high generation of heat, which can lead to tissue damage, which is why RTMS therapies are delivered usually 4 to 6 seconds on and 24 to 26 seconds off for 37 minutes daily for 6 weeks. So what we did was we experimented with different kinds of intensities and speeds, and we found that we could deliver EMF to the brain as high as 300,000 cycles per second. And we could do it safely. Another thing we learned with Neurofield is, along with being able to entrain the brain by simply giving it a pulse and having the brain following along with that, we could disentrain the brain. We call it dehabituation. The dehabituation system in Neurofield is basically a random number generator, which applies 4 different random numbers to the brain every 100 milliseconds. And when the brain tries to mimic 4 different frequencies going that quickly, it quickly gets disentrained and disrupted. As soon as the system shuts off, the brain reorganizes itself immediately. And this is good for different kinds of cases, which I'll address in a little bit. In my clinic, I have a 4-room clinic here in Bishop, California, where we are working with Neurofield on a daily basis. And our workup now is really focused on getting the history from the patient, and we get cues on everybody that comes here. I have found it to be incredibly important to have a map to guide your hand in order to understand what it is that you're going to be doing with the patient, and to match the patient's symptoms and clinical presentation along with the map data that you obtain. This conceptualization is, I think, one of the reasons why we're so successful in our treatment efforts. One of the things that I like to look at is the pre-morbid history of the person. And we get a lot of autistic kids versus people with TBIs. We get a wide variety of cases. One of the things that we really look at is, does the brain have a history of being able to run normally? And if it can, that really guides our hand versus whether we do disentrainment versus entrainment types of therapy. If the brain knows how to reorganize itself and it has a history of running appropriately, then we disentrain it and then we stop and see what it does. If it can reorganize itself appropriately, then great. The person responds very quickly to therapy, and we can get done with therapy anywhere between 10 and 15 sessions. But if the brain doesn't have a good premorbid history, for instance, like a kid with autism, then we can disentrain the system and then entrain it immediately using neurofeedback. We have found that model works very quickly and has sped up the process of treatment considerably. So what we use in the clinic is what we call the real-time Z-score procedure. This procedure is it's a two-pronged approach. Basically, we use the EMF to drive the brain at a specific speed, while also using operant conditioning to threshold on a specific frequency band. So the EEG will give us that information, and we can see where there's deficiencies and where there's excesses in each frequency band. And we match that to the patient's presentation, and then we apply treatment. An example of this would be a child with attention deficit disorder where there's an excess of theta and a deficiency in low beta. And in those kinds of cases, we'd want to see low beta increase and we'd want to see theta decrease. So what we do is, using the EMF, we give the brain 15 to 19 cycles per second, and we drive the brain along using that speed, while also thresholding on the theta activity and trying to decrease that operantly. And the procedure works quite well, actually. This is what it looks like on the screen. In this particular setup, the brain is getting 1 to 3 hertz of electromagnetic field, and then it's also getting threshold set on high beta. So we will give a pulse, let's say at 1 hertz for 4 seconds or 10 seconds. We can vary the time. And then once that pulse shuts off, then we measure 4 seconds of EEG, and we take that data and we run it through the NeuroGuide Z-score database. If the Z-scores return back within the range that we set in our threshold, then Neurofield sees that as being a positive thing, and we give that specific frequency again. The procedure can run anywhere between 30 and 45 minutes. We have found it to be incredibly effective in rehabilitating the brain in such a way that it's very fast. The response is actually very quick. So I want to show you some examples of how we do this. In this first case, we have a person, a female, 48 years of age, who had a pretty significant history of depression, anxiety, chronic insomnia, had taken a number of different meds, benzodiazepines. She was pretty despondent when she started. We used the real-time Z-score and did 22 sessions. On the left here is her pre-treatment map, and you can see the excess of high beta in that map, along with a little bit of delta there in the back of her head at 0.2. And after 22 sessions, you can see how high beta on the map on the right resolved itself, at least for the most part. We also see these massive coherence changes and asymmetry changes as well. This person started to respond early on in therapy, but we continue on with the person so that we can lock in the effect over time. And just like with regular neurofeedback, the more you do in a lot of these cases, the more effective the treatment outcome. Here's a person with PTSD. This is a Vietnam vet. This specific individual suffered from, he had been blown up multiple times. He was one of the rat guys in Vietnam that would go underground. He had significant PTSD. Anytime he talked about war or would watch stuff on TV with the current issues around the world, and it would really, really bother him. We used the RTZ protocol on him as well and found him to respond very nicely. On the left there, you can see his pre-treatment map, and you can see these very, very high levels of theta activity in his temporal lobes, but it's really widespread. And you can see after 12 sessions there what he looked like. And this individual received low beta EMF. So we basically drove the brain right over those areas where the highest amount of theta excess existed. He would come in, he was a really good observer of self. He would come in and tell us that he was remembering things better, his flow was better, he was less foggy. Another really good response. This next case is a male, 45 years of age, that basically fell off of a moving golf cart. He was body slammed when he fell off it and smacked his head right at PZ to about P4. He came into treatment a little after 8 months after his injury. His wife had called me initially. He had very little insight into his injury, had very little idea as to how his injury affected his life. As he would say, he thought that he was perfect. So one of the things that we noticed was on his map was that he didn't present like people that I would typically see with TBI. I actually posted something about this on the NeuroGuide forum recently. His brain was significantly deficient in delta activity. And being a lens practitioner, Len Oakes talks about suppression in the brain basically being locked down. And it's one of the theories that I've been entertaining for years now. And I'm a believer in it now. But basically, when the brain gets locked down, it doesn't show you where the real injury is. It essentially tries to go down to a very low power state. And the physics behind that really makes sense to me. So one of the things we tried to do with this individual was give him some inflammation reduction and to dehabituate those sites where it appeared to be the most severe. Let's see. On the left there, you can see his pre-treatment map. And again, this really low delta, he's a low power state across the board, but obviously delta has the greatest amount of deficiency. As we started to dehabituate his brain and this delta starts to correct itself, on the map on the right there, we start to see, this is about, I'd say 30 days, the first 30 days, we start to see an excess in delta at PZ, where that's the site of the injury. And we can start to treat that then. Now on this next page here, you can see what happens when we start to actually address it directly. It corrects pretty quickly. And the phase lag issues that we saw there, if you look, I'll go back, you can see the phase lag is pretty significant at PZ. And when we put 15 to 19 cycles per second over that for basically 45 minutes per session, it corrected itself and started to look like this. As a result, he starts to develop insight into his injury. He says to us, he didn't realize he was as bad as he was, and he did what most people with TBI do, which is they stop and say, this was, I didn't know it was this bad, I think I'm getting worse. He would start to say that he recognized that he didn't have a sense of smell and that his sense of smell was getting worse. And in my experience, when you're able to hear that from a person, it's a sign that they're getting better because they are able to develop insight into the nature of their injuries. On this next case, young man, quite intelligent, body dysmorphic disorder. This is probably one of the more severe cases that I have ever seen. And I saw a lot of these cases when I worked in hospital. But this individual would mutilate himself because he just did not like the way he looked. And so he would cut moles from his face. He filed his teeth. He dyed and cut his eyebrows, cut his hair continuously, and had enormous amounts of anxiety about going out and being in public. So we obtained a state-dependent EEG on him. And the map on the left shows what he looks like when he's just idling. And the map on the right shows what he looks like when he's thinking about his body. And you can see how the frontal high beta increases when he's thinking about his body. So we began treating him using the RTZ procedure over FZ, C4, and P4, and basically slowing down those portions of his brain. It was a really interesting response because the next time that we mapped him, he started to tell us that he couldn't create the feeling that he would have when he thought about his body. It bothered him, but it didn't create the feeling of anxiety that he normally experiences. And so this is another state-dependent EEG. On the left is what he looks like when he thinks about his body. And on the right, he's thinking about his body, but this is after treatment, after receiving treatment. And so we see these significant changes in the high beta absolute power, along with real significant changes in coherence there. On the next case, this is I'm taking you through the process of what I call the low-hanging fruit to the more difficult cases. Cases like anxiety, depression are pretty easy to treat with Neurofield. Of course, when you get cases like this with schizophrenia, we don't know if this is going to help or not. We live here in Bishop, California with, it's a very small population, and I know all the psychiatrists. And one of the psychiatrists asked me to get involved with this young man who had some pretty significant hallucinations. He was medication resistant. They had people trying to work with him on a daily basis, but he really was not responding well to much of what they were doing. And this is what he looked like when we got started. And you can see this delta low power EEG, and more interestingly, when you look at the coherence, you see this frontal lobe hypocoherence, this real disconnect in the frontal lobe. But again, a low power EEG. We do 15 sessions of Neurofield, and we followed it up immediately with 19-channel Loretta treatment, all in the same session. We would we would disentrain his brain for a period of time, and then shut off Neurofield and put an EEG cap on him, and then train him with Loretta neurofeedback. Now, this combination was something that we used in an effort to get his brain to let go of the current pathology that it was basically hanging on to, and to use the neurofeedback as a way to guide guide the brain into a normative level of functioning. This is an example of the dehabituator setup that we use with him. In a Neurofield, you basically set up the amount of cycles that you want to use. You can set up the frequency bands you want to run, the duration, the amplitude setting, and whatnot. And it'll run through and give 4 random frequencies every 100 milliseconds, or longer or shorter, depending on what you want to do, in an effort to disentrain the system. Now, one of the things that we saw almost immediately, and this was very uncanny, this is a screenshot of the NeuroGuide Loretta 19-channel Z-score. What we saw here was, at first I thought was my instrumentation was breaking. I didn't think it was real, but we see this deregulated brain kind of going along, and on the bottom here, this is basically the threshold here, and you can see the threshold set at 1, and at a minute 30 seconds, the brain appears to organize itself. Well, we saw this initially, and I thought this has to be an error. This is, something's wrong with the amplifier, or something's wrong with my computer. So I asked the young man to come back, and so we replicated it. And we found that if we disentrained the brain would automatically allow Loretta to organize it. Loretta was able to, we were able to get better Loretta treatment much faster. And you can see there was periods of time there in the treatment where the brain is deregulated and it goes back to a regulated state. So we replicated it again, and we found that not only was this finding consistent for this particular patient, but we started to see it with other patients as well. If we disentrained the system and then attempted to train it using neurofeedback, we were getting a more consistent result. So this is what he looked like on the left when he started, and then on the right as treatment progressed. You can see how delta began to correct itself. And importantly, on the coherence, you can see how the hypocoherence also corrected itself. This had a tremendous impact on this young man, simply because he was able to become more calm. It didn't make his schizophrenia go away, but it did reduce his symptoms to such a degree that he became functional. One of the great things about this was the county mental health staff that had to work with him every day was pretty much blind to what we were doing in here. And so as he was treated, we were able to ask them what their impressions were. And they were very surprised to find him becoming more functional. This is another example of his progress here. And on the left here, you can see the phase lock durations. I was very curious to see if the phase reset dynamics in this particular individual would change. And sure enough, they did. Phase locks changed. On the left there, you can see what he looked like at the beginning of treatment, and then as treatment progressed. And the phase shift dynamics changed as well. The brain was not shifting hardly at all. It's written the -3 z-score there on the left showing you that phase shift durations were very, very short, and that during treatment they increased significantly. When the brain is able to shift, it's able to communicate in various locations, various hubs. When we see this kind of change in a person, then we start to see them get better. This is a brief outcome of what happened with this individual. His symptom ratings dropped. He'd say that his anxiety had gone down quite a bit. The mental health staff said he was stable, definitely much more functional. He ended up getting a job, and his physician was able to reduce his Zyprexa because he was getting sedated by the Zyprexa, which is another thing that we see not only with Neurofield but with typical neurotherapy. As somebody starts to get better, the medication works better and they don't need as much. And so having a physician that's willing to see that and address that problem by not giving more but by reducing the dose, that's a good way to go typically. I've had to sit down with multiple physicians and try to explain to them that they don't need to give more if a person's getting sedated. They don't need to add a stimulant or something else. They simply need to back off the dose of the med and then see how the person actually does. Let's go to another one. This is an individual. I actually just posted some of these maps on the NeuroGuide listserv. This is a gentleman, a 65-year-old male with Parkinson's disease. He agreed to be a test subject for us, and we started with him last January. The idea was based on my thought that the thalamus, being a delta generator, was not doing its job. And my understanding is that the thalamus needs to generate delta in order to control the swinging gait of the reticular activating system. The reticular activating system has to be controlled because it's excitatory. And essentially, if the thalamus is not kicking out enough delta, then that gate can swing open and close rapidly. And I believe that gives rise to the symptoms of Parkinson's. So the idea was to see if we could get that thalamus to start generating more delta. So this is what the individual looked like when he came in. As you can see, there is excessive high beta and beta, but most specifically there, you can see the delta is 3 standard deviations below the norm. And you can see hypercoherence across the map there, which is very significant. After 7 days of treatment, we do another Q, and we see this. He has an almost immediate change. His tremors reduce. He reports that he's starting to sleep better within 7 days. And he started to say that there were points in the day where the tremor would actually stop, but it would be for very short periods of time. Again, this is what he looked like when he started, and then this is 7 days later. So then we continue treatment with him, and he goes through treatment for a total 6 weeks. And this is what he looked like at the end of 6 weeks. And what you see here is this really high level of high beta, and he actually looks worse in some ways in this map than he did when he began. But the delta definitely stabilizes. We see this massive change in delta, but we also see a massive change in high beta. Neurofield was only giving 1 to 4 cycles per second, so we were not in any way driving the brain any faster than that. The brain automatically began going faster on its own. We see this hypercoherence really come to the surface. Now, he was giving himself 2 sessions per day for 45 minutes per session. And again, this is for 6 weeks. So I told him to hold treatment at this point, and we would see how he was doing. Now, he reported a significant decrease in his tremor. By this point in the therapy, he started to report anxiety, and rightly so with this amount of high beta, which concerned me. I had not seen this map. I hadn't been able to give him a QEEG. He had called me up and told me he was feeling anxious, and I said, stop the treatment and let's have you come in and do the Q. So after 6 weeks, this is what he looks like. And this is 6 weeks post-treatment. He reports to us that he feels really good. His strength came back. He was able to start writing again. He could write his name. He was able to, his motor ability had improved significantly. He would report longer periods of the day where the tremor would stop altogether. And as you can see from this map, the high beta that you saw in the previous map reduced significantly. Delta also reduced. It became a little bit more deficient, but nowhere near where it was when we started. And let's put these two together now. So that's the pre-treatment map, and there's the post-treatment map. And you can see these huge differences in the expression of delta and of beta and high beta. And you can also see the changes in hypercoherence. And this is a really interesting finding for us because beta really didn't appear to be changed in any way, whereas it actually appears to be more hypercoherent than when we started. But the rest of the frequency spectrum did change pretty significantly. Again, you know, no map is perfect, and I wouldn't expect it to be that way. But his outcome and the way that the progression of this disease appears to be expressing itself is very interesting. The plan is to continue to do QEEGs over a period of time here and to follow him for the next 12 months and to map out how his brain responded to the short period of treatment. What's really interesting is he feels that the progression of the disease has been interrupted at this point because he feels himself getting better instead of worse. And so time will tell here. But again, another very interesting outcome. Our current system now has, it's a 2-channel EEG system. We have a 19-channel EEG that's going to be released this June. And we're going to expand our current 2-channel Z-score model that we use in Neurofield to 19 channels. And actually, that's happening right now. And we're actually field testing our stuff right now to expand the model. The other things that we're doing is integrating more of what NeuroGuide can do into Neurofield, and we're looking at entire phase reset dynamics, which I find to be some very, very interesting metrics to examine because we see definitive changes in phase lock and phase shift and almost everybody else that we work on. So we're going to add more phase reset dynamics to our procedures and see how we can help to facilitate the process. What time is it?
12:46.
Ah, very good. Okay, I came in just a little under. I think I'll end at that point and take questions.
Okay, great. I'm going to just unmute people, so beware I'm unmuting you.
Okay.
All you.
And I'm going to wait a minute to see if other people have some questions first.
We're just everybody just about unmuted. So make sure you mute yourself when I unmute you. All right, there's John, Kathleen. Okay, you are all unmuted, all 25 of you. So,
Questions?
any questions?
Yeah, hi, Nick. This is Kathleen. And my question relates to medication. And of course, I tend to have the big, complicated people who walk in here on 6 medications. And as you know, I'm getting ready to use Neurofield when I figure it out, sort of with your help, hopefully. But I have one person in mind right away, but she's like on like 6 or 7 meds, and it's just driving me crazy. And I just want to get her off. Do you have any comments about, your experience with these complicated polypharmacy cases and how the meds kind of peel away or don't?
Well, fortunately, being a physician, you can make the call as to whether or not you feel a person should be on these meds, and also you can also make the recommendations as to whether or not they should come off them. It's always difficult, especially if somebody is taking benzodiazepines or antidepressants. We have found that the SSRIs are obviously some of the most difficult to get somebody to come off of, and fortunately we have some local physicians here that work with us in such a way so that they create a very slow titration schedule where they take them off the med over a period of, like, say, 3 months or so. I think part of it is providing enough support for the person as they come off the med, so that they don't spiral out of control and that it doesn't occur too quickly. So, for instance, 1 med at a time, and to make sure that you're doing it slowly. That's some of the advice I could give right from the get-go. It really is case dependent too. Does that help?
Yeah, I have a question.
Yes, hi, Nick. This is John.
Oh, go ahead.
Hey, John, you want to put in your question, and then we get Vic next.
Okay, sure. Yes, thanks for a great presentation, Nick. And 2 questions. What are counterindications to using this? And can you comment on any problems with electrohypersensitivity?
Sure. Both good questions. I think that both of those kind of tie together. Some people don't respond well to getting this kind of treatment. They can be really sensitive to electromagnetic pulses, and one of the things that we try to look for right from the get-go is if a person is sensitive, and if they are, they can have a pretty significant reaction that usually manifests itself in a person being what we say is wired or tired. They can get an abundance of energy for a period of time. They can have insomnia. They can experience agitation, or they can experience a real fatigue in which they go to sleep right from the get-go. And when we monitor a person, we are asking these kinds of questions, and we try to get them to tell us what's happening with them, so that we can alter the duration of treatment. And so with people that are sensitive, we want to decrease the duration, and sometimes we decrease it to the amounts that are, it almost feels ludicrous to the amount that we actually decrease it, but they do respond, and so you really don't have to push the brain too quickly. So to answer your question, when people are electrically sensitive, we want to definitely decrease the duration of treatment. We also want to, I don't believe that one size fits all. If Neurofield is something that's too much for a person, we will use other methods, such as just regular neurofeedback, Z-score neurofeedback, HEG. We can try different methods if a person can't tolerate the treatment. Does that answer your question?
I think so. Sometimes there's a delay because they can't get their mute button working. Vic, did you have a question?
Right. Richard, can you hear me okay? Because I'm in the car with my iPhone.
Yep.
I just wanted to not lose the opportunity to say hello to Nick. And,
Hi, Victor.
Hi. Nick, the one theoretical question that pops to mind with regards Len's approach of starting with the parts of the brain that are most functional versus, applied neuroscience is starting with the furthest, the most deviant, and how you go about trying to work with those slightly different philosophical approaches to where to start.
Mm-hmm. Mm-hmm. Yeah, that's a difference in our orientations compared to the lens. The way that we do things now is we look for the greatest deficits in the map. So, and if it corresponds to your symptom set, then we go right at that deficit and we attempt to increase it. So, not increase the deficit, increase the power. So if we see somebody with like I was showing you, a deficit in delta, then we will give delta in an effort to increase it. That we have found that works the majority of the time, and it's pretty rare that people actually don't respond to that philosophy. The lens approach is markedly different from our approach, and it's a different kind. It's a different kind of treatment altogether. Really, is EMF is the basis of Neurofield, and the lens stimulation is a whole other animal essentially. So I could just tell you from this point in time, and in the 5 years that we've been doing this, we have found that addressing the deficits and thresholding on the excesses has turned out to be I'd say a very predictable procedure that works, I'd say, better than 80% of the time. And so when we can replicate those outcomes each and every time and get some good results with very, very low percentage of side effects, that's the way I'd like to go.
Thank you, Nick. Keep it up.
You're welcome, Vic. Thank you, Victor. Other questions?
Yeah, Nick, this is Rob. You've had a sort of a discussion, I think it's on LinkedIn, with Neurofield and tinnitus, and wondering what you're finding with tinnitus.
Yeah, that's a real interesting thing that we've been dealing with here. So one of the things that I was looking at different treatment modalities, and the name of the person who developed this is escaping me right now, but basically there's an audio treatment where you have headphones on the person and you play a number of tones to the person, and you try to have them identify the one that matches the pitch of their of the ringing of their ears. And so I was looking into that, and I was thinking that's an interesting therapy. But one of the problems with it is that it can only really work on the 8th cranial nerve. And my guess is that the tinnitus is more widespread than just the nerve itself, probably affecting different hubs and different systems. And so we decided to experiment with a different kind of technique where we would give frequencies from 1 to 100 hertz. And we'd have a person have their eyes closed, and we'd put these the coils, the Neurofield coils, right over each ear, basically. And when the person notices a decrease in their tinnitus, we would have them signal us with their hand. They would just raise their hand while keeping their eyes closed. And what we noticed was there were certain frequency ranges that were individual specific. It was different for every person, that would decrease the volume level of their tinnitus. And once we defined what those ranges were, we would program Neurofield and then give them those ranges for a period of 30 to 45 minutes. And then what we found was actually unexpected. We were hoping just to simply reduce the volume. But what we found was it actually would altogether stop the tinnitus for a period of time. And this period of time ranged anywhere from a matter of hours to over a week for some individuals. And so it's a treatment that we're still experimenting and working on. But what we found is that you can use it as a maintenance treatment for a person and really keep the level down quite a bit for a person. And they're more than happy to come in and get that kind of treatment on a regular basis simply because of the relief that they get. Unfortunately, it does not stop the disorder, but it does reduce the intensity of it quite a bit. So we're continuing.
Have you noticed anything, if you've looked at maps, that would stand out? I have a patient I ran today, and what I noticed when I was running him, and I was working at F3, F4 based on some papers we actually sat and talked about here last week with Richard, and he had these periodic spindles that included beta, high beta, and gamma. And they would come every minute or two. They would be very, very high, then they would settle down. And initially, when I was treating him, he reported feeling a little bit agitated, but it settled down. And I stopped the treatment. I just put him on for 5 minutes and wanted to just watch his EEG to see if those bursts were coming up, and they still were, but not in the same frequency. Have you seen anything like that with maps or with your observations?
I have. And that's one of those that leads into the whole Parkinson's thing in terms of the delta generator in the thalamus.
Okay.
And it makes me wonder whether or not the reticular activating system is being controlled by the thalamus, which is one of the things that I would expect to see. And so I would hypothesize that gamma high beta spindle that you're seeing is the reticular activating system kind of going off on its own and going out of control, so to speak, which probably is a generator for the tinnitus.
I would wonder about that too, because he describes his as sort of it goes from more intense and loud to less intense and loud, and he's trying some different treatments. One is where he puts on a headset and he listens to these different tones that sort of go along with what he's experiencing with, I guess, with the tinnitus itself, or just as a treatment. I have to get more information from him about that. He had it on today when he came in. I thought he was listening to music, but it's more of a treatment. But so you've observed the same sort of thing, yeah. And I was curious. I actually recorded that EEG, just real curious to see if you had observed anything similar. So thanks for that.
Yeah, I would love to take a look at it if you want to share it.
Can you look at Brainmaster EEG?
Sure.
I'll send it along to you. I'll send it along to you too, Richard.
Yeah, I'd love to see it.
Okay.
The more we understand about that, I think the better we can do.
Okay, great. Thanks. Well, we're at 1 o'clock, Nick, and unless there's a real quick question, and I haven't heard anybody else come up with a question, we'll kind of wind this down, but that was an excellent presentation. Thank you very much for taking your time today. I know your very busy schedule, and to give us an overview of what Neurofield's doing and all that. Now, there's someone just whistled. Does that mean you want to ask a quick question?
Yeah, I'm having trouble with my mic, but I have a quick question, and that is, so Nick, I heard you say I should use my old Neurofield T1 1000 to use it before a session to open the person up and make them more receptive to other forms of neurofeedback. Is that right?
Yeah, is this Gary Ames?
That's right.
Ah, hi Gary. Yeah, you can use the dehabituator in Neurofield to disentrain the brain for a period of time prior to doing a neurofeedback session. One of the things we're looking at, though, is giving the person a little bit of a rest period in between doing the actual dehabituating and then going to the actual neurofeedback part. So right now we're trying to figure out how much time is optimal. But we have found, like when we do intensives in the clinic, we have people come in, let's say at 10 o'clock in the morning, and they might do 45 minutes of Neurofield, and then we have them come in the afternoon, or 1 or 2 o'clock in the afternoon, and then run a 30-minute Loretta session. And so they have a period of time in which to rest, essentially. Neurofield really taxes the brain, and so just make sure you give them some time to rest in before you actually do the neurofeedback part.
Thank you.
Mm-hmm.
Well, all righty. Well, we'll wrap it up for today. But again, thank you so much, Nick, for your time. Great presentation, and hopefully we'll see you at ISNR this year.
I will be there. Thank you for having me. I really appreciate it.
All right.
All right.
Okay, everybody, have a great weekend. For those of you in major weather areas, stay indoors and warm or whatever. And for those of you up in Boston, follow directions. That whole city's on lockdown, so be good. Bye, everybody. See you next week.
Bye-bye, everybody.
Bye-bye.
Thank you so much, Nick. It was great.